You keep using the word atherectomy. It's a bad word here in the United States. Every patient's coming to me because of a New York Times article and ProPublica article about atherectomy that stemmed from a Johns Hopkins researcher and vascular surgeon who said atherectomy, the use of it, is leading to amputations. But it was interesting because once all of these articles came out and it created this frenzy, I sat down with both you and Dr. Marco Monzi about the indications for atherectomy, and we put together a well thought out piece on when a patient should expect atherectomy and when it's not indicated. Would you mind sharing some of those indications for atherectomy, or what I liked in your last conference at Click, which they provide this amazing conference every year to teach doctors around the world the most advanced tools and techniques and when and how to use them. You actually have shifted to using the phrase vessel preparation to include not only atherectomy, which is those roto-rooting devices, lasers, etc., the sanders, and the drills in a sense, but also to include IVL, which is intravascular lithotripsy, which is using audio waves to crack the plaque, which you were mentioning during your discussion on the CFA and treating the CFA. So
exactly.
what are the indications?
Let's start from the beginning. Atherectomy is not the holy grail, but it's a vessel prep device. So it's going to allow us to remove plaques or to micronize calcium, depending on the device you are choosing to use. And it's going to allow us to increase the lumen gain and maybe to increment the vessel wall compliance. So giving back the vessel to a pulsative vessel in calcified arteries. So is indicated in all the patients? No, I don't think so. It's risky in patients without indication. Could be risky, yeah, sure. So when to use it? Common femoral is a nice place to use it, but you must select. For example, all those cases that most of the physicians select from my side are not my preferred. I don't like to use atherectomy in heavy calcified plaques in common femoral because you cannot protect both SFA and profunda, and the risk of embolization is so high. But you have a fibrotic plaque after surgery, yeah, good. The risk of embolization is lower, so some of the dedicated devices can perform well.
And when you say embolization, just so some of the patients understand the risk of embolization, meaning small particles that can go downstream and end up lodging in your toes, or even worse, if they get through your toes, they could lead to a stroke or even a heart attack.
Exactly. This is the definition of embolization. The small particles of tissue that can be soft tissue or calcium can migrate and can arrive to the distality and occlude the previous patent arteries. If it's happened with clots, it's the same name, embolization, emboli, but clots are cells, fresh cells that can be solved with a pharmacological support. Compared to tissues, tissues means plaque or calcium that cannot be solved with pharmacological support. So it's important to consider that no any patient have an indication or has an indication for atherectomy. Patients that more frequently underwent to atherectomy, in my personal opinion, are not good option, good candidate for atherectomy because the risk of embolization is so high. I like atherectomy for in-stent thrombosis or occlusion or stenosis. I think if you can protect these vessels distally, is a good option to remove plaque and tissue inside the stent. I really like atherectomy for popliteal artery, these reasons in which, if possible, to avoid stent is good option. So leave nothing behind strategy in popliteal artery. But again, you must be sure that you can protect the tibial arteries with a distal protection device, with a filter.
With a filter, yeah.
Yeah, otherwise, maybe it's better to avoid atherectomy. And you must think about, I personally think about the tissue I have. If I have a heavy calcified artery, or you can use an orbital atherectomy that micronize the particle of the calcium, or otherwise, maybe it's better even with the filter to avoid it. I usually take in account the length of the lesion I am going to treat. If you are going to treat 6-8 centimeters, it could be safe compared to treat 20, 24, 25, 30 centimeters because the risk of embolization increased too much. The same for below the knee and for below the ankle. With orbital atherectomy, we can guarantee excellent result. And small arteries, I used to show multiple cases of below the knee and below the ankle atherectomy in calcified arteries with excellent results. But it's important to consider if we have a patent outflow that will allow us to have a washout during the atherectomy. It's important to consider the technique, how we are going to do that. It's important to consider the speed in which we are going to use the device, which type of device we are going to use. So we have multiple options today. Not all of these options adapt properly to all the patients and to all the lesions. As well, atherectomy is one of them, but it's not indicated always.
One of the biggest mistakes I think some doctors make, and I'm not a doctor, but I've observed thousands of hours of cases, not only in your lab, but around the world. And when I've seen some doctors use atherectomy, it's almost like they think that they need to go 0 to hero and remove as much plaque as they can, as much luminal gain. And here the FDA uses the idea of lumen gain when how much lumen gain do you get using this device? But I look at it and I see more success in cases like yours and Dr. Monzi's, your partner there, that you're just trying to remove that much plaque and get that much more blood flow to be able to heal the wounds and to be able to get a person back on their feet. Less is more, less trauma is better for the patient because less trauma, less use of these devices, using them in a minimal fashion, right? Reduces the hyperplasia, the patient's immune response, where they get all that scar tissue mucking up the artery again sooner. But less is more approach, less trauma, less chance of mucking up those arteries again sooner versus later. Do you agree?
Sure. Yeah, sure. I fully agree. Less is more in some cases, as well as the opposite. I mean, when you have a good indication to reduce the barotrauma, to remove tissue in a safe way, and to apply drugs like drug-coated balloons to, again, inhibit any type of hyperplasia or cells migration, it's the top. It's the best procedure, but you don't have all these indications every day in every patient. So sometimes, yes, less is better, is more, just to manage the patient with a safe procedure. For example, fragile patient in which if you have a complication, you will have many complexity or problems to manage this complication. Sometimes just pass a wire, inflate a balloon, and check your result from the clinical perspective, not only from the vascular perspective, is the top. So as I said, it's difficult to give a straight message, do that or never do that, because we must to tailor our procedure, we must to adapt our procedure to every patient, specifically related to the baseline clinical condition of the patient, related to the vascular lesions, to the extension, to the location, etc., etc., etc.
Yeah, I think that's why we struggle with global standards on this, because it really depends on the presentation of the patient.